Thanks everyone for staying. I think all of you will agree that that was a great round of speakers. So give all of them a big round of applause. Thank you. And then my name is Saurabh Gupta. I'm an interventional cardiologist, but clearly, there's a lot for me to learn. Just as we were.
So basically, hopefully you guys have this list in front of you, and this is where we're going to do targeted crowdsourcing while you're listening to Q&A. So this is not just a spectator sport. We want each of you involved to whatever degree you feel comfortable. But basically, you'll notice on this Excel spreadsheet, and it's a little bit hard to see up on the screen, that there's two yellow arrows I want you guys to focus on. Basically, the third column is the hospital status. So again, we want to first of all know what every STEMI center is. Where are all the STEMI centers here in Oregon? I think we've got most of them on the list, but you'll notice we're missing a little bit of information on Salem, Eugene, Roseburg area. And I think that'll kind of complete our STEMI centers. And then we also, what's more challenging usually, is to try to figure out the referral hospitals. So are there any referral hospitals in your region? And if so, do they transfer directly for primary PCI, or do they give lytics and then transfer? And that goes now to the, let's see if I can get my mouse to work. The arrow on the right is the hospital's STEMI center. So ideally, a small referral hospital will transfer their patients to a STEMI center. So we want to know the name of that STEMI center that they're going to be going to. And so that would be very helpful. Hopefully that makes sense. The STEMI centers are in the, if they're transferring, it's in the between the two little blue lines on the right side of your Excel. And ideally, if you know the kind of transport mechanism, air versus ground, that'd be very, very helpful. Again, if we can't, whatever hospital we can't categorize, we'll just basically say that they're not on the grid, that they're, quote, a yellow target lesion that we'll need to fix that, but that they're not yet connected, they're non-transferring and non-PCI. And I think we'll all agree that's not where we want to have our STEMI. And so we want to, again, have no yellow dots left on the map ultimately. So thanks for the pause on that.
Okay, so as I was noticing the panel, what do you guys notice the most? Bow ties. Now. So I thought I'd email my friend Joe Weiss about this few slides. Bow ties in the Western culture. Go to the next one. Oh, I could do that?
This is not going to be nice. Yeah.
So, for those of you thought that it's the uniform of the preppy oppressor, this is just like bow ties going through culture. Here's, for example, the savior of the free world.
There you go.
White polka dots on navy. And I think Brian is a huge fan. The savior of the union, he kept it plain. And then what would quantum theory be without the bow tie? So now, of course, there is no guarantee of brilliance. But if you can handle it, let the adventure begin. All right, so with that, we'll go on to Q&A. The two members of our panel that I would like to introduce are Ritu Sani. So Ritu is a very experienced emergency physician. He's agreed to join us on the panel. He is the current president of the American College of Emergency Physicians.
No, the National Association of EMS Physicians.
And then he was also the state director for Oregon EMS and Trauma System. And he saw my daughter in the ER a few weeks ago. So just a great guy as an ER physician.
Did he have a bow tie?
No.
I did not, but, Doctor Who says bow ties are cool, so.
And then Modaya is a faculty member. He's an associate professor at OHSU. He's the EMS director for Tualatin Fire and Rescue, which covers part of Metro Oregon. He's also a very respected national investigator on the ROC Consortium and has done a bunch of stuff on hypothermia and those protocols. So thank you for joining us. And of course, you've met the rest of the panel. All right, so I guess I'll start off with the question. Do people have more questions? Those are some great questions on there. And I tried to categorize them in several areas. So I guess we'll start with hypothermia, cardiac arrest, and those general line of questions. So Mo, we'll start off with you. What do you think, cath or cool? So here's your scenario. Somebody comes in, they've had out-of-hospital arrest, now they have a return of spontaneous circulation. What do you think? Should you take them to the cath lab, or should you just routinely take them to the cath lab, or only take them when there's a STEMI, and then we'll see what the panel thinks?
So I think that this topic is a huge topic, and I think it's controversial depending on who you read. But I think the current take is definitely, if it's a presenting rhythm of VF, witnessed, you would take to the cath lab, period, regardless of what the ECG shows. I think you would probably also take if the ECG showed STEMI. Those two I think take for sure. The question of when to cool, I think you can actually start cooling immediately. Actually, there's even data that the best time to cool is actually during resuscitation. And we're going to see some trials presented this year at the American Heart Meeting that might change how we think, because there's 2 trials that are actually looking at intra-arrest hypothermia. But I think you can start cooling, and I think you can continue doing the cath lab procedure. That's what I would do. So I would do both.
Manesh and Fred, what do you guys think? I mean, how do you tie this together with how the national AUC criteria are looking at it, and Fred, how the guidelines are, how the databases are looking at it, right? Because you take 3 of these patients to the cath lab, 2 of them die in a quarter, and suddenly my adjusted mortality looks off the chart.
Yeah, so I'll speak first. There's really nothing with appropriate use on this, but I guess I would say first, if I just step back from the cool cath situation, and I think it speaks a little bit to that last talk, was to say that our threshold for taking someone to the cath lab based on ECG is pretty low, right? And that's okay. And then we don't know the right answer, but I'd say that's okay. So our practice pattern's been somewhat similar to what's been described. We cool as soon as they get to the ED or EMS, but usually in our ED. If VF or any hint of STEMI or any concern of STEMI is occurring, then we take them to the cath lab. And our entire faculty is comfortable taking them to the cath lab because, one, if they don't have a culprit lesion, then at least right now, that's not a PCI-related mortality. And 2, if they do have a culprit lesion, then you're there for the right reason anyway, and you're trying to open up the artery that's occluded that led to the cardiac arrest. And you see stories like the ones you just saw where you really make a big difference in someone's life. So our practice would be to say cool and cath, but not cathing every single cardiac arrest, looking for either a rhythm or an ECG-based criterion.
I think we follow essentially the same practice at the University of Colorado. The caveat is I'm a general cardiologist, so I'm not going to get in an argument with Manesh about stuff like this. But the point you brought up last, this issue of mortality and taking on cases of patients with cardiac arrest, is an important one. I think we have to always consider the potential unintended consequences of measurement, which is something we can do better with, and certainly hasn't been a primary focus of measurement efforts, specifically with respect to NCDR and with cath PCI, where this might come out in terms of risk-adjusted mortality. We're following the lead of Massachusetts, which has done a lot of work at a statewide level on their cath PCI data and actually use it as a platform for public reporting. And they developed a definition of compassionate use for PCI, where such patients would be removed from the denominator for the purposes of mortality. And there's a specific definition of that has to do with receiving CPR in cardiac arrest at the time of presentation, particularly complex coronary anatomy and so on. And that is moving its way into the national registry thanks to the work that's been done. In Massachusetts was written up in JAC a couple of years ago, I think, this definition of compassionate use.
So, Brian and Ivan and Ritu, can you make a case, for example, regardless of what the ECG says, that maybe if your presenting rhythm is VF, that you take all these patients to the cath lab?
I think you can make a compelling reason based on what Ivan said. If 1 out of 3, if you're getting them with a return of spontaneous circulation, and then 1 out of 3 of them is likely to have a ruptured plaque, I guess you could do it. I mean, that certainly wasn't my experience in years past. I trained with Mike Kopis and Len Cobb and Doug Weaver back in the 70s, and back then I remember Len Cobb very clearly saying they rarely ever had a myocardial infarction. But that was a population of people that had a lot of congestive cardiomyopathies and a lot of arrhythmias. All those people nowadays have implantable defibrillators. Those people get zapped and wake up before you can even dial 911. And so if you look at the number of people that are having VF now in King County, it's dropping precipitously. And so what's happening is you're getting the people who you didn't know were going to be at risk of VF, which are probably the myocardial infarction. So I think there's a tendency to probably cath now more than I would have 3 or 4 years ago based on the data driving the change. The other thing, which I think is a very key point, is the paramedics, the EMS, has to give us the best feeling of what's happening at the scene with the return of spontaneous circulation. Because once you commit to hypothermia, you're committing tremendous resources and emotion of family for a week. Huge, I mean, nurses and drips coming out the wazoo. You know, if they're moving semi-purposefully in the field after they're shocked, I don't hypothermia because they're going to get better. But the problem is they're often intubated and then they're paralyzed. And so by the time they get to the emergency room, I guess we got to go with it. So we really need EMS to give us the best estimate the last time they were conscious before they intubated and got paralyzed. Is it a go or not a go?
So in many EMS systems now, including in the Portland metropolitan area, we initiate hypothermia pre-hospitally. So when we get ROSC in our little burg of Lake Oswego, where I'm the medical director, where we have a 28% survival rate from cardiac arrest, we take our protocols, and Mo's shop, we have the same protocol, but if after 5 minutes after ROSC, if they haven't gone back into VF, if they are not awake and alert, then we start hypothermia in the field.
Pushing, I mean, not the core to get the.
No. I mean, if they are, if they're having purposeful movements, if they're following commands because they're intubated, then we don't start it. But if they are pretty much anything else,
just moving, even if they're not responding to you, but
yeah,
moving purposely, you'd give it.
I think so. I mean, it depends on what you described as purposefully. I mean,
Dyscerebrate's one thing,
right.
The corticate's another, but there's other quasi-purposeful movement.
Right.
And that's the value that I
think we would. And then, you know, in Multnomah County, where we sit now, they're practicing intra-arrest hypothermia. Same with Anchorage, Alaska. I think Seattle may be moving in that direction too. So basically, the first bag of fluid that's hung on a cardiac arrest in Multnomah County or in Anchorage, Alaska, is cold fluid from the beginning. And then the other emphasis that we make is a post-cardiac arrest 12 lead. So we are one of our first STEMI saves was our very first STEMI save when we implemented STEMI or ECGs was actually one that the computer missed, but the paramedic overread, which was fabulous. But one of our next ones was a post-cardiac arrest we expect both. And I would say that much like Mo's answer, that's what we would expect. And I think the big problem is how do you figure out who is a cardiac arrest, who is a sudden cardiac arrest of cardiac origin. And I think the best tool we have is if VFVT on the monitor or the AED delivers a shock before you get there, you just presume it's cardiac. I think there's a lot of sepsis out there. You know, those would not be worth taking to the cath lab. That's what we expect.
Ivan, any?
Yeah, you know, I think it's a complex decision. It's interesting to see the different answers that have come up. And I think a number of points. One is we should be careful about the post-ROSC EKG. It's not a perfect tool. And we know it's always been the time-honored tool for cath lab activation. But there's definitely evidence, especially from the Paris ProCat registry, that quite a few people with a non-diagnostic EKG post-cardiac arrest still have an occlusion that deserves a cath lab intervention. So having said that, I think it's really critical in these more challenging patients to always consult with the cardiologist. This is less linear than your standard STEMI that's walking in that's got the alpha on. These are complex patients. And so I think the decision to cool into cath should be made in consultation. And as an ER doctor, you know, at that point I need to consult with at least somebody else, at least get a second doctor to, are we in agreement on this or not? One
of the causes of ST segment elevation is an electrocardiogram within 5 minutes of an electrical shock. The STs are often elevated, so on our little form, you know, if you're going to make the diagnosis of STEMI or no STEMI just from the EKG in that setting, we ask the EMS to wait 5 minutes after the last shock, because if you get it in the first minute or two, it can look like a very nasty classic STEMI.
Manesh or Mo, anything on the horizon which helps us cool better than we do? Like even in the cath lab or out there in the field, like, or is cold saline what we're stuck with? Or
so I'll say in the cath lab version, it's like the aspiration world right now. There's a whole gold rush of companies that are making things to try to cool patients. before there's any. As some of you know, there's probably some cooling trials in the late mid-2000s for STEMI, just for acute MI, to say, could we reduce infarct
Cool MI, for example.
Cool MI, other funds where we would do venous catheters, and of course there's a whole set of different things. And so I think there are some innovative ones, from beds to invasive catheters, and of course other cooling mechanisms. All of that's coming. I don't know of any very large, well-defined study yet to do that, and I'll yield to you to tell me about other cooling mechanisms. Right now, I'll tell you at Duke, we still use cooling ice bags and cooling fluid in transport in the ED until we get upstairs, and then there's other things going.
So I think with regards to cooling, I think the controversy exists on how to cool, when to cool, how long to cool. Those things still have not been well sorted out, and I think there's a lot of technology that's coming out. The things that seem impressive recently are nasal cooling methods, either perfluorocarbon or just dry air. The other one that I'm quite impressed with is a product out in Austria, which is called EMS Cool Pads, which are pads that can be applied that bring your temperature down within the hour to your core temperature you want to get at, and you can add or take off, so it's very easy, and it's much faster than the Arctic Sun, much faster than the invasive pieces that you have to go with the IC cool catheter. So I think that technology will continue to evolve in this area. Clearly, the simpler the better is the key, and keeping with the KISS principle. So for EMS, complicated stuff doesn't work. Simple stuff works, and that's kind of what we're hoping for.
Okay, perfect. So I think from that we'll move on to the next segment. And the next segment I kind of thought was, what are the roles here? So Fred, here's a question from Ed. Where's Ed? He's right there, which I think is a great question. Can you explain all these registries? I mean, what the hell are they? how do they relate?
All right.
How do they relate to, so just give us a brief synopsis of, and not every single registry, but how do they relate to Door to Balloon? How do they relate to Mission Lifeline? What is the difference between CATH PCI and Action and Get with the Guidelines and Mission? So just give us a two-minute overview on what these might be.
I'll focus on those two maybe, just in the interest of time, because I'm sure people would like to get to dinner at some point. But with respect to CATH PCI and Action Get with the Guidelines, the CATH PCI registry primarily focuses on PCI, a subset of which is acute STEMI. A lot of it is elective PCI. And some of it's, acute coronary syndromes that, may or may not fall into Action. So it's a pretty broad spectrum of the PCIs that are being performed in the vast majority of PCI-capable hospitals. There is a door-to-balloon time metric within CATH PCI that'll come with the executive summaries for the subset of patients with STEMI. Action Get with the Guidelines is the registry that supports Mission Lifeline, because Action Get with the Guidelines is an MI registry. And so there are data with respect to angiography within Action Get with the Guidelines, but they really focus more on the timing of the angiography. So within Action itself, there's not a lot of detail on the angiogram itself. A lot more focus on the comprehensive in-hospital care of myocardial infarction, which may or may not include PCI. And so Action is really the data engine underneath Mission Lifeline. And that's what's used, because again, it's an MI registry, it's not a PCI registry. So they're overlapping circles, but they're not obviously entirely synonymous either. Does that answer your question, Ed, or is that?
Fred, you forgot to mention the good news, though.
Well, Mission Lifeline is more really a program, is really this program, a program of coordination amongst several components of the community of practitioners and healthcare professionals who are taking care of patients with acute MI. It includes EMS. It includes STEMI receiving hospitals and STEMI accepting hospitals and so on. So Mission Lifeline is really more a focused, as we heard from some of the other talks, a focused program of coordination that includes the entire community of caregivers, supported by a data engine, which is Action Get with the Guidelines. But Mission Lifeline is really talking about improving the care of patients with STEMI from the perspective of the entire community that cares for these patients, including EMS in the variety of different hospitals that care for patients.
And just on a related question, how do these, what are your visions for, as on a national level, on how they interface with the emerging or existing EMR systems?
Right, so it's an important question. As I said during my talk, I don't think by any means that EMRs will supplant registries, because registries, at this point, given the way things work and as EMRs start to take hold, a lot of registries are viewed as, well, it's a data collection activity. And that's understandable. It's taken a lot of effort to collect a lot of these data in parallel with workflow, which is one of the problems with the registries. There are active and I think very fruitful collaborations between NCDR and many of the EHR vendors to work on facilitating the collection of data in workflow. To get those EHRs to put data in the registry. The thing to remember, though, is that EHRs are just sort of an electronic way of keeping records the way we traditionally do if we don't think about it very well. That is to say, garbage in, garbage out. You put unstructured data into an EHR, it's very little more useful than unstructured data in a written record. And so part of the challenge in working with them is maintaining the data standards that underlie so many of these measurements and making sure that the data we get out of them is in a structured format that can be translated into performance measures and thus translated into action.
Ivan, you had...
One plug that Fred forgot to mention was that there's a lot of interoperability now between Cath PCI and Action Registry. So depending on the type of form, 30, 40, I think even up to 50% will cross-populate fairly easily. So for those of you doing Cath PCI for a long time, that makes it a lot easier to join Action Registry as well.
Manesh, as you see these databases more widely adopted, do you see a scenario where, for example, all of this information at an operator level, at a system level, at maybe a cath lab nurse level, being publicly available and queryable? So will this be in the Oregonian, and is that something that...
So I'm not here to scare everyone, but I do think that the idea that the world will not have available information, one on an institution and maybe on an operator level, is unlikely that it won't eventually get there. If you just think about where healthcare wants to go. If you step out of cardiology and just say, what do we know about our surgeons, our surgical colleagues that do operations on our patients that need bypass surgery, depending on where you live in the United States, there is not only institutional but sometimes operator level data available, some states like New York and others. So I think what I would say on this is that first, I think to Fred's credit and Ivan and others, I think there's a huge movement to try to reduce the data entry information that has to go in for all the registries, and where common elements are available, that'll be the case. For physicians and others, I'll talk about this some tomorrow, I think we have to figure out systems of evaluating one another and peer reviewing one another that aren't solely responsible on the data registries, maybe regional, local ways of figuring out ways that we do peer review so that we can provide each other meaningful feedback, because obviously our profession, like many others, is under important scrutiny.
Well, you know what, Manish, your comments remind me of the Boston Globe headlines. There were 2 bad hospitals identified in Boston recently, in the last few years, the Beth Israel Deaconess and Mass General Hospital. Yeah. And both of those bad hospitals were really due to STEMI patients who were cardiac arrest, who didn't die because of a bad cardiologist, but died of a brain death. So that's, I think, QI gone wrong. And I think the way to address that really is it should be regional accountability to some degree. It's not the Beth Israel's or the Mass General's cardiac arrest or resuscitation, it's the community of Boston. And how can we leverage the talents of Boston to best take care of this patient, every patient like that? And I think that may be a way to fight this who's a good doctor and who's a bad doctor when it's not really always that accurate.
And I think that's where it's important we take, why it's been so important that we've taken some professional responsibility for engaging in the quality enterprise. And it really reflects the importance of attribution. Right? So it's one thing to say, well, we're going to hold a specific interventional cardiologist accountable for their procedural complications. It makes sense to sort of attribute things at that level, maybe at the interventional cardiologist level. But what about beta blockers at discharge? So Manesh does a case and the patient goes into the Duke system, and what wouldn't obviously ever happen at Duke, the patient leaves without a beta blocker. But are we to hold Manesh responsible for that? or if we're talking about, yeah, it depends on who you are. I guess you're chief maybe. So yeah, right. So, but and similarly, if we're talking about the behavior and the performance of a system, is it right to sort of put the focus, the spotlight on the interventional cardiologist? Well, we want them, of course, to be an advocate for change and have them get engaged in the change. But it's not right to attribute it to them. So I think it's something we really need to focus on. And I'm glad that, again, we've been engaged in this enterprise, so we can take some charge also over where we think the attribution should be for a particular measure of performance.
So, and to a related question to you, Ritu, in your role, for example, as the state director for EMS and then as a president of the National Association, essentially, what do you think the role of government is? What has been your experience? And, for example, should it be self-policing or should it be governmental regulation? I mean, should this be mandated?
See, I used to say I'm from the government, I'm here to help, but now I used to be from the government, and now I'm here to help. I believe that that government can't run healthcare. That the government can't, and I'll say it, I'm a pretty liberal guy, right? This is Portland, which actually makes me a till of the Hun compared to a lot of people. But I mean, I learned this in my time penance at state government. But what the government can do is provide framework for people and organizations to come together to do the right thing. It also, if done correctly, can provide protection. And I think that's really a lost fact. And so when people come to the table and say, we want to do this ourselves, we don't need government involved, I think it's tough to then turn around and ask the government for protection. And a lot of these activities, as we talk about, we don't want the front page of the Boston Globe to say this anymore. Well, having government protection around some of the activities is how you do that. And in reality, personally, I think behind closed door, every hospital should know what, not only that I'm hospital N, but I should know who A, B, C, D, E, F, G are, so that I can call my colleagues up and say, what are you doing over there that makes it so much better? But I think there's still fear around that issue. But so the government can provide framework. And Brian talked about the trauma system, and the vision that we had was sort of a regionalized framework that really strongly relied on those people in a community come together to figure out what are the goals of our community. Because ultimately, a community set of values drives what they want to do in a community, and the community should set the goals. What the framework provides, though, too, is standardization. So if community X decides we have $10 to spend this year, and we want to spend $9 of it on vaccination and $1 on cardiac arrest, and community-wise says we've got $15 so we can spend more on both, they should be able to compare each other evenly, apples to apples, oranges to oranges. And I think that's the other piece that I think sort of a standardized government framework can provide.
Manish?
I was thinking, this isn't so much of a political discussion on who controls or how healthcare is going to be, but I'll just say to the prior kind of question going into this is that, we're trying to provide I was impressed by the slide on door-to-balloon time for the cath lab, right? And we've done that some for our operators. And we've now generated a dashboard for our cath lab operators that has a bunch of stuff on it used from some of these things. And just by starting the dashboard, it includes things like start times or going to fellow conference or what's your turnover or do you put patients in research, but also vascular complications and door-to-balloon and other things that matter. And so, one of the very unique things in cardiovascular practice, at least at our place, and I'm sure around the country, is that you don't often get that level of detail about yourself in some meaningful way that in a safe environment where you can act on it. And so I would just say that's something that should start to happen because and it should happen for the discharging physicians and the CCU physicians and the non-invasive imagers. But that level of data is probably going to be meaningful because that's the way you can affect change.
So no cardiologists left behind at Duke.
Yeah, so we're trying, there's plenty left behind. We're trying to get them all on, right?
But I think the flip side is it's a silent rising water floats all boat. You're never saying you're bad. Everyone just gets the report, I assume, and quietly sees, oh, I'm an outlier.
That's right.
I need to improve. And it's, I think, a very effective way to float and improve quality without being punitive.
Yeah,
right?
we haven't put all the names to the letters yet. You get your name, and then you see all the other letters, right? So, so you don't quite.
So you're saying that if I have SG on my cath report, don't assume it's me? Brian, alluding to your presentation, you had one or two slides which were funny, but I think the question is real. Are you going too fast? Are you going too fast? Like, is there a limit to, hey, you can't really have a door-to-balloon time of 13 minutes because it's just not safe. You're missing the dissection, you're missing
Absolutely.
the PE. So how do you guard against those pitfalls? And then the related question I have for Ivan and Mo is, what are your feelings about skipping the ER altogether?
Well, yeah, that's the whole issue with with going too fast. I mean, you're going to get the false activations. Okay, false activation, EDCCs have died, rarely hurts anybody, and you learn a lot. But if you did, by the same token, what if you're reading that same EKG out in a hospital that is not a STEMI receiving center but gives thrombolysis? Now you've given a drug that has all of the complications and none of the benefit. And I think that we try to move quickly. You try to use good sense. I mean, you can smell some of the dissections, you can smell some of the pulmonary emboli. You can't smell them all. You're going to get burned. It's just a matter. If you haven't been burned, you haven't done enough. And I think an 18 to 25 minute door to balloon time is commendable. And I worry about people doing it 10 minutes because you don't even have time for the betadine or the chlorhexidine to dry off. So
you're saying as a system, even though there may be individual drawbacks, but as a system in general, you're far ahead if you look at a population-based
I think
statistic.
So. I think we're doing well enough, and I think that the savings that will come from here on out are probably the savings come from patients identifying that they're having symptoms. That's where the 2 to 3 hour delays occur. Saving 5 minutes in a cath lab, it's good for one's ego, okay, but it probably doesn't make a heck of a lot of difference, and it might even, as you're alluding to, might hurt somebody if you're not being as gentle with that left main coronary artery and slamming the catheter in as fast as you can. All you got to do is lift up a tiny little lip and you're in trouble.
Manish?
Yeah, I want to just absolutely echo that point. We do a lot of fellow training, and there's going fast is great. But even when Jamie Jollis started this, he and I would get in arguments because he's like, do you need to shoot the non-IRA? So, it got to the level at our institution where they're saying, do you need to shoot the non-IRA? And we were saying, well, just stay out of the lab. Once you get to the lab, let us do what we usually do the way we do it, because we're used to doing it a certain way. And the first time you just go straight to the right coronary, the person has a left main lesion and an LAD that you didn't identify before you went and put a DES in the right coronary. And so there are a lot of things that the interventionalists think about and do in the procedure that I would just say, part of it's sort of like measured aggression. You want to go fast, but you don't want to go too fast because you're going to miss stuff or lift a plaque, et cetera. That's step one, I think, for the speed set. And then the second thing I think is, I don't think the activation issues, those are important, but it's once they, so for a long time I argued with Ralph Brindis, why don't we just call it door to access? That takes all the emphasis off going from access to balloon. What's all this stuff about? Why do you care if I did it in 14 minutes versus 13 or 10? And we did a trial called CRISP AMI with balloon pumps and looked at infarct sizes, and the balloon pump took 9 minutes to put in. No one would argue with it, but it didn't change infarct size much, but the 2 hours the patient was at home actually affected him. Ralph's point, I think, is fair, which was to say there are some places where there are people who take pictures before the interventionalist gets in to do it, and so for those institutions and that kind of a process, that's right. So maybe there is still some advantage in saying door to device. But I think this is one of those things that we struggle with in the cath lab a lot. They're sort of fast enough to open it fast, but not going so fast that you're careless.
John Wooden's famous words, be quick, but not in a hurry.
The second related question to Mo and Ivan.
So I think in terms of bypassing the ED, I think there's great data that I think you can do that, and it's actually done quite often in some systems that are more integrated. The Canadians are a good example. In the city of Ottawa, every STEMI identified EMS goes to one single center. But it takes courage to be able to get to that stage. It takes courage to have the discussions and the understanding that what's good for patients is probably what should overlie the system. Sometimes we lose that, and that's where those personal discussions have to happen. I think that the slam dunks, you can go right to the cath lab. I think there's a gray zone that's not so clear, and I think those need to stay in the ED first to be sorted out a little bit better. But I think that there's some straightforward cases, classic presentations, where I think taking extra time is probably not going to help. Although I do agree clearly that what we need to do is educate the public about calling sooner and using 911. Not only do they not call quickly, but secondly, they don't use 911. And so we have this great system out there that can do 12 leads, transmit, do all these things, activate, but they don't use it. And so if we're ever going to really make the system work and really benefit, we've got to get everybody in. The key in this actually is the community. If they come on board, I think everything else kind of begins to flow nicely.
And I have a whole section on pre-hospital ECG, so I'm going to skip that for a minute. But how do you know if you don't know, Ivan?
You mean the ED bypass?
Yeah, if they're simple or not is based on whether you know, right?
You know, so it's interesting. I have two answers to that. There's sort of the academic answer and the operational answer. I was involved with an action registry abstract, and there's a publication in print and circulation where the action registry looked at the rate of ED bypass. And I was the only ED physician on that. And there was a lot of excitement amongst our cardiology colleague, Akshay Bagay from your group, led that you can save up to 20 minutes by bypassing the ED. And there's a lot of excitement about that, but we pushed back a little bit, went back and forth, that there's times to do that safely, and there's a time when that's very dangerous. And I think operationally, the time to do it where it's safe is during the daytime where the cardiologist shows up at the ED ambulance ramp. When an interventionalist is at my ambulance door, most ER docs are saying, you know what, we eyeball each other, the patient looks stable, the EKG is a STEMI, go to the cath lab. But at midnight, even at Duke, I don't think there's 24/7 cath lab. They have to stop in the ED, and so we're there for you. So I think it's this constant interplay. So yes, you can bypass the ED, but you have to be careful, and the best way to do it safely is have the interventionalist there. And if they're not, then be careful. And the other, you'll probably get into this a little bit later, I really strongly believe that false positive activations are the cancer of STEMI systems. And if you have too many of those, it drains a lot of enthusiasm and resources. I know you may have other questions about that. So we, as the ER doc, need to be aware of false positives, especially when you're bypassing. The last thing you want is a 90-year-old demented patient in your cath lab or a 20-year-old benign early repole in your cath lab. Neither of them belong in your cath lab.
So just one, I think the part of the other piece to that answer is this. The cath lab is no longer a place. It's a state of mind. Okay? It is.
I love that.
It absolutely is. And so there's, there's no reason why the cath lab can't start in your emergency department. And so I think that's part of the answer, because I think Ivan's absolutely right. The last thing you want is a patient who's potentially unstable in a cath lab without a physician there. So, the cath lab team and the ED team are colleagues, and we work together. And I think the right way to approach it is to work together. And so there's no reason why having your interventionist there, okay, let's go. But more than half the time, they're not going to be there. So teaching when the cath team comes in, they come to the emergency department. When the cath team's not here yet, the emergency department has a checklist of what the cath team would be doing now. So there's no reason why you can't already get the right height, weight for the proper catheter size. Do all the things that the cath team would be doing. And then if you run into a patient who's a perplexing problem, you've got the trains on the tracks, but the emergency physician can stop the train and say, whoa, this is pericarditis. We need to slow down. So I think you have to think of the cath lab as a state of mind. When the patient arrives in my facility, we are all the cath lab, and we're moving in that direction.
Fred,
I take it one step further. I would say the cardiologist has to be bold enough on that circumstance. When they get in there, the patient's all prepped and ready to go, and all systems are going. We stop it. If you look at that EKG, you now have had a chance to pull up your EMR, and you've looked, that EKG is unchanged. This patient has had 2 other admissions to the ER for similar chest discomfort, no change in enzyme. The cardiologist can be bold enough and stop it right there. And yes, you wasted the gown and a few catheters, but that's in the best interest of the patient.
Fred, final word on this?
Well, I would just say that, I think we have to be balanced about this. And, I've heard some people say, gosh, a lot of door-to-balloon times are now below 60 minutes. Maybe we should drop the threshold, as if somehow we need to adjust to a curve. I've been adamantly against that, because there's no evidence to support that much of a faster approach, and I think that's where you do get into trouble. False positives, and not all false positives are the same, obviously, and there are some benefits in some cases, but they really can erode, morale, and they can erode the effectiveness of the system if you're overdoing it. They have consequences in terms of cost and other consequences to the patient. So it is this issue of balance, and I think we're doing, this intra-hospital issue we're doing very well with, and we should keep it up. But I think we shouldn't, continue to get too aggressive in some respects. So.
All right, so moving on to ECGs. I mean, God knows what that has to do with STEMI. But let's start with pre-hospital ECGs. I mean, what does the panel think? There's like, I think that's the maximum number of questions. So, the broad summary is, should this be across the board, across all types of patients that are appropriate, obviously, and then across the country? I mean, do you need to legislate this? And then the second related questions are, who pays for this? What is the standardization schema that you would have such that the systems are cross-compatible with each other? And then we'll move on to the false activation story. So, Rita, you can start off, and then we'll just say.
Well, I think that horse long gone from the barn. I mean, I think compared to 5 years ago, we did a survey 5 years ago when we thought nobody in Oregon had 12 leads, and turned out almost everybody did. So I think the standard of care in an ALS EMS system is to have 12 leads, and to have paramedics who are trained to read them. So I think the problem or the question now becomes, well, how do we expand that? I mean, do you really need a paramedic to do a 12 lead? I would say no. I think you can do a 12 lead with any level of provider. You probably can't train that provider who only went to school for 100 hours and only does 12 hours a year of training. You can't train that provider to read the 12 lead, but most of them can read star, 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 acute MI, suspected. And we know that there are missed, well, they took out the suspected, didn't they, Tim? They changed it. There are now, you can train an EMT basic or what's now called an EMT, to put the monitor on. If you're going to unfortunately, most of these places are places which are transmission challenged because of geography. But you can certainly train them to place the monitor on, to transmit if possible, certainly call on the phone and read the top to somebody on the other end. And so there's some of that. I think the other piece too is there's some literature in the EMS world that shows that almost half of the 12 leads half of the STEMIs identified in an EMS system are not classic chest pains. And so our system teaches our paramedics that if you suspect any acute coronary syndrome as a possible cause, you do the 12 lead. You just don't do it on a classic chest pain patient. So when you got a 70-year-old diabetic woman who's weak, we do a 12 lead because some of those are going to be STEMIs. And then the third benefit really is not so much the STEMIs that are identified, but you will identify a certain subset of patients who have dynamic-looking EKGs that have improved by the time they got to the hospital because of nitroglycerin and aspirin. And we've had a number of patients who have normal ECGs, and they've got ST depression on their pre-hospital, and they went to the cath lab in a timely manner, not like now, and they identified lesions. So there's a huge bunch of benefits to these. If
they hadn't gotten that EKG in
Right.
the field, they might have been sent home with 2 negative enzymes and 2 normal EKGs in the ER.
Right,
Yeah.
exactly.
Ivan, transmission and data standardization.
So I'm a huge proponent of transmission. And if we asked our kids about this, our teenagers, they'd say, why aren't we transmitting every single EKG? You can take their picture, send it to Canada, to China, anywhere around the world, and yet I can't get an EKG from someone's living room and get it to the hospital, to the ER doctor, and to the interventionalist at home at 2 in the morning in bed. And I think we've worked a lot on those systems in LA County. We're gradually getting there. An interesting thing that we've learned recently that we're adopting is there has to be a culture of transmission. EMS needs to be continually transmitting as almost a routine, and ED and cardiology need to be asking for those transmissions. And we've basically now instituted a rule in many parts of LA County, or many hospitals have independently started this, where they want all EKGs transmitted. And that way the paramedics, as the Navy SEALs say, we train like we fight and we fight like we train. That way when you have a STEMI, it's no big deal to transmit because you do that with every chest pain. And the transmissions just go to an EKG inbox and are there for review. But I think that's something that we need to have. I think at the end of the day we ask, what is a STEMI? And there's many different definitions, and including the ACCHA guidelines. There's the clinical syndrome, the EKG, the biomarkers, the angiogram, the nuclear study, and hopefully not the pathologist. But at the end of the day, at time zero, it's all about the EKG. And so I think that EKG is a critical piece of information. It's a cornerstone, and I think it should be transmitted. So I'm a huge transmission proponent, but I know some people may give me some pushback.
I think there's no real pushback for it, and I think it's just innovation waiting to happen. Look, most of us already probably believe that the cell phone will do the ECG and send it to people wherever we are soon enough. So, I mean, I don't have to hear about Eric Topol on a plane doing an ECG on someone and resuscitating them.
He's here next week.
Is he?
Talking
Well,
about
you
that.
can ask him. And then I saw him on Colbert using the phone to look in the ear and all that stuff. So I am saying that I agree with transmission. The number of times everybody in the health system should be able to look at that ECG that's being done would support a lot of faster decision making. And again, I don't know, I'm sure I just came from San Francisco. There's some kid who's going to figure this out and make a lot of money, but there has to be some innovation here to get ECGs at a cheaper way than the current systems that put them in the trucks that cost the money for transmission.
So more for Multnomah and Washington counties, which is the Portland metro area. What have some of I guess some of the challenges have been?
So we started our 12-lead program in 1992 through St. Vincent. So we've been doing it for a long, long time in Washington County. The challenges initially were transmission. Transmission was not very effective in the beginning because there's a lot of problems getting the signal through, and you'd sit there, try it again and again. That's very frustrating. It slows things down. Again, if you want a system of care, you've got to be able to make things very quick, efficient, and fast. Things have gotten better, and my approach to 12 leads transmission, I was not a big fan of it because I think you can train to pick up what I call, everybody picks up the tombstones. There's again, we're talking about black and white, which is what makes it very hard in medicine. There's a lot of medicine which is gray. I think the black and white ones are very obvious. The normal one and the abnormal one are very straightforward. There's a middle group, however, I think benefits from transmission. But that's where I disagree with transmitting everything, because then I think, like for example, my medics do 100 ECGs. They will find maybe 2 to 5 STEMIs. So we're asking them to transmit every one of those, which is going to be a lot of information that someone has to go through. So I think we have to get smarter about what we transmit, not just everything. We got to pick the ones that are obvious. I don't think we need to transmit. We can just activate. We can transmit if they want to see it anyway, but that's fine. But the key ones are where the transmission is going to affect the decision making at the hospital end as to what to do, particularly when the medic can't make the decision. I think that's how we need to think about those tools.
I would say I agree. I would say two features. One is, if the activations occurred, that's fine. There should still be innovation just to say you can get that transmitted. But for all the others, where the activation is being considered or it's unclear, that's where this false alarm thing would really help with that whole driving in, getting to the cath lab, having everything in place, and then having to make a decision when the patient arrives. Some of that could be headed off.
So Fred, talking about this false activation thing, I mean, how do you count false activation? I struggle with it morally, right? And here's how I struggle with it. I struggle with it, for example, if I say, hey, this was a false activation, yet I thought it was not false enough for me to not have them go to cath altogether. Is that really false? That means, so is the definition of false wrong? I mean, is the definition of false that a cardiologist would not have taken you to the cath lab, not after an angio, oh, it wasn't the STEMI?
Yeah, I think it's a great point, and I think it's an area where we need a better taxonomy in some respects, and that there's a variability in terms of how false activations have been defined in the literature. I think there are some false activations where, as you point out, patient still benefits from getting an angiogram, so you may get someone with what turns out in retrospect to be a Takotsubo. Well, they're going to get an angiogram anyway, and so that could be classified as a false activation, but the reality is that hindsight's 20/20. And then there are those cases where you have someone with clear LVH and repolarization abnormality that's been stable, and that maybe if you had all the information at hand, you'd say, this is not necessarily someone that we think really needs to go to the lab. That's a different story. So I think part of it is developing a better taxonomy for what these things are. And then by using that as a framework, we can then go and attack the issue and try to really balance the false activations with making sure that we're not missing, missing the real ones.
We ran into that problem early on, and at a time when you were trying to build a collaborative system, people bristle at it being labeled false activation. We changed it, the taxonomy, to was it a protocol compatible activation, or did they miss it? Okay, did it fit the protocol? We asked the paramedics can only operate under a set guideline of rules. Did they overcall it because it truly wasn't there or not? And so that really, it didn't make it nearly as abrasive to the people who, and it helped clarify, oh gosh, well, my data nurse right here, she has noticed, and when Ivan and I were talking about it, the rapid atrial fibrillations have a much higher risk of false activation. My brother 15 years ago was catheterized by a very well-known cardiologist. He had atrial flutter. It was painfully obvious to me when I saw the EKG. He had wide open coronary arteries at age 42, but the flutter would look like ST segment elevation due to the rush to the cath lab.
Okay, so I think we're on time. Thank you for all of those answers. Any other questions from the floor? So again, a round of applause for our panelists. I think that, thank you very much.
Sort of 8 minutes, we're just going to do a quick wrap up and sort of set the stage for what would a STEMI summit look like in 2014. We've talked about a lot of these things, and I just want to underscore what the guidelines reinforce just very briefly, that all communities should create a regional system of STEMI care that includes assessment and continuous quality improvement. I think we've given a very good argument for that today. That includes that on the EMS and hospital-based activities, which include D2B and Mission Lifeline. We talked about reperfusion therapy with primary PCI and the concept of first medical contact, a new concept for a lot of different programs that have not really thought about it in that way, rather from a door perspective overall. This highlights the fact that immediate transfer for primary PCI, the ideal first medical contact to device time goal is less than 120 minutes. Although they're showing data in 2005, this is actually what the guidelines does reference is 2005 data that only 10% of individuals reach this goal with a median time in the United States of 149 minutes. And the door in, door out, or DIDO time that everybody's highlighted in the work that Tracy Wong and others have done at Duke, that only 11% reached that time goal as well. I think, to be perfectly honest, most of our quality improvement work has focused in on the acute care side, and it's always been about faster and faster in these regards. We've focused in on these areas primarily at our primary PCI centers. I think we should be reinforcing this for all of our transfer facilities as well. They're going to be administering fibrinolytic therapy. And then this was just brought up on the panel, but I do want to focus on this because I think when we start talking about quality improvement, we have to think of ourselves as a community. And so the focus is on pre-hospital care. And I want to just put out a couple of pointers just really quickly that this has been reinforced, it's in the guidelines, but patients with STEMI do not seek medical care for approximately 1.5 to 2 hours on average after symptom onset. And that has changed very little over the last decade. The delay times are greatest among certain groups, and I think in particular from a community approach, we should be focusing on the educational piece, that it's greatest in women, African Americans, the elderly and Medicaid-only recipients. We see a much greater rate of delays in those. And so those racial and other disparities are areas that we should be focusing our quality improvement efforts on. And a third of STEMI patients, we've already highlighted this, I think, experience symptoms other than chest pain. Why do people not seek medical attention? There's inappropriate reasoning that the symptoms are self-limited or not serious. They attribute their symptoms to other pre-existing conditions. There's often, when you talk to people and they ask, why did you not show up for 4 hours, often you hear a fear of embarrassment should the symptoms turn out to be a false alarm, or reluctance to trouble other individuals unless they're really, really sick. There are also a lot of really still prevalent pre-existing stereotypes of what that is. The Google picture of a man clutching his chest, or the original Net or Atlas pictures where you see somebody trudging in the snow who is diaphoretic, that is not the picture that necessarily we see ubiquitously today. And then the lack of knowledge about the importance of rapid activation, the benefits of calling 911, and the availability of reperfusion therapy. And this is just highlighted on the panel, but while greater than 98% of the US population is covered by 911 service, only 60% of STEMI patients in 2011 were transported by EMS. People are getting there a different way. We talk about walk-ins. Usually it's finding a neighbor to take them. They're on the street and a stranger takes them in and drives them in. And 1 out of every 300 patients with chest pain, this is not necessarily STEMI, suffers a cardiac arrest en route to the hospital. There's also a significant association, this has been highlighted many times today, that exists between arrival to the ED by EMS and an earlier delivery of reperfusion therapy. And this was just echoed a lot about the availability of a pre-hospital ECG. So I would like to see not only it being focused in on the in-hospital quality improvement initiatives, but from a community perspective, how do we educate our communities about the importance of using 911, recognition of symptoms, particularly in different groups that may not recognize symptoms as frequently overall. Data is needed to identify gaps in care and drive quality improvement. And I do want to correct one thing. A lot of us have been under the perception that the state had actually purchased a systems level report. They are contemplating the purchase of a systems level Mission Lifeline report. But I think we've made a convincing argument today because we don't have ubiquitous participation in Action, Get With the Guidelines registry, and thus, in order to participate in Mission Lifeline, you have to have that action participation. While we know there are barriers, cost, infrastructure, I think that this is an important enough effort, and the amount of information that comes back to you that drives rapid cycle quality improvement initiatives, not to mention MOC and all the other benefits that are coming from these type of initiatives. I'd really like to, as an ask, echo what Mike led in with, that we'd like to encourage all primary PCI STEMI centers throughout Oregon to contribute and participate in the Action Registry and participate in the Mission Lifeline initiative. Interestingly, I believe we have 2 centers that currently participate in Action but don't participate in Mission Lifeline where there's no additional cost. It is just an okay to relinquish the data to then be carved out in Mission Lifeline. And then again, thanks to all of our EMS colleagues, I think this is imperative that we continue to partner with EMS to drive continued improvement in pre-hospital care. And with that, I really want to extend a special thanks to all of you coming out on a nice Friday afternoon, all of our speakers who have traveled, in some cases from short distances, in a lot of cases from far distances. This has, I think, been a tremendous success. I wish more people could have taken advantage of all of the benefits that all of you have shared today. I'll put in a shameless plug for tomorrow attendance at the symposium where we have a great group of speakers overall. But again, I want to give a special thanks to all the people who stood up at the podium today. We couldn't have done this without you. So thank you very much and enjoy your weekend.